Hello. Hi folks. Eric Sodicoff here. I am a general internal medicine doctor in Philadelphia, suburban Philadelphia, and we're here to talk about primary care considerations and applying that the principles of LCHF or low carb to the primary care world, which is something which apparently is pretty rare, and we're trying to we're trying to see a lot more people get involved with that these days. So the title of my talk is A Shift in Perspective to Primary Care. So a little bit about myself here. I have an internal medicine doctor in Philadelphia, suburban Philadelphia. An internal medicine doctor is basically a primary care doc for adults. We see basically all adult problems. I do everything from taking care of primary care stuff like your routine physical to problems that you have, you know, if you have a rash and that sort of thing. I take care of that sort of stuff for you. The other things that I do is we also do a lot of hospital work. So hospital work is basically, so unlike a lot of doctors these days where you're just strictly in the office or you're strictly in the hospital, if you show up in the hospital and you're my patient, I'm going to be taking care of you. We take care of a lot of other people's patients, and so that's a lot of the stuff that we do. Sometimes I even still do a little bit of night work. It was previously a full-time hospitalist basically, and now here I am doing kind of more preventative stuff, but I go back and forth. So recently I had a shift in my focus. I switched from being strictly an internal medicine doc, doing hospital stuff, to actually becoming more involved with preventative measures, including things like taking care of obesity, diet stuff. This was really kind of a shift in focus for me, because a lot of people really don't like talking about it, even in primary care. It seems like it's an issue which is not really heavily addressed by a lot of my colleagues, and I thought that it was an underserved problem. So when I went into obesity, I kind of already had a sense of which way I wanted to go with this. There's a number of different ways that you can handle the problem. The problem can be handled in a number of different ways. If you go to a conference, you're going to find that there are people there who are handling obesity by using low-calorie approaches. You'll see people handling obesity by using meal replacement plans. And by that time, I had already done a lot of reading, and I kind of found that the low-carb approach really seemed to make a lot of sense to me. So I really decided that that was going to be my shift in focus. So one of the big things I like to do here is I like to bust myths. It's just a big problem here. People come in, they expect their doctor to say things like, you need to exercise more, you need to eat less, it's your fault. And I kind of come at them, and I have to prepare them to be surprised, and I just tell them, listen, this is something different. This is going to be a different approach here. You're not likely to hear this from a lot of other doctors, and just, you know, kind of lay the groundwork for hearing kind of an approach which is a little bit unorthodox, period. So how did I get involved in this area? Well, it started off when I was actually in college. I started off, my dad was actually a medical school professor, so that's kind of in my blood, hanging around medical schools and labs and those sorts of things. So in college, actually, at Temple University, I got involved in a lab where we actually were studying lipids, believe it or not. Lipids basically being the basics of fat, and that's where I learned things like, for the first time, lipoprotein lipase, hormone-sensitive lipase, PUFA, MUFA. These are all kind of the basics, biology and physiology of fat metabolism. So this was something I was involved with. I actually ran a machine where we were actually measuring the fat composition of hibernating animals. So it's really kind of, this was something that we dealt with, and I knew a little bit about the basic biology way back in college. You go to medical school, you learn about the biochemistry, the hormonal control of fat, and then somewhere along the line, we forget about that. I mean, this thing about gluconeogenesis, the action of insulin, and how with all the many different things insulin is doing around the body. Very interesting. They teach you about this, but then there's somewhere a disconnect between what that basic biology and what eventually gets practiced on a day-to-day basis, where losing weight and gaining weight has to do with calories, which again, in my mind, for many years, this disconnect here was just a kind of a vague. I kind of forgot about one, moved to the other one, and I kind of forgot about it. Didn't quite make sense. So why don't more doctors stress diet? Big issue. A lot of doctors don't think that diet is effective at treating a lot of diseases. They follow the guidelines. The guidelines really don't produce any sort of tangible results. So the big thing is that you get people who have these diseases, you send them to a dietitian, or you counsel them yourself, eat less fat, more healthy whole grains, more fruits and vegetables. People generally don't find that very satisfying. It doesn't really work all that well. And then it just doesn't work, it falls apart. Maybe if they make some changes, you see a small improvement, but in general, that type of thing isn't very effective, and most doctors know that. And so they tell you that because that's what everybody says. Try that first, and we know that it doesn't work. And so we quickly move on to the next thing, which is basically drugs, because we know that they do produce some results. Are they important results? Maybe not. Maybe they are, but they're not exactly really great results. We can definitely, if you put people on blood pressure medicine, you will definitely see their blood pressure drop. If you put them on a cholesterol medicine, like a statin medication, you will definitely see a drop in that LDL number, and it looks like something's happening. And since we're told that LDL will prevent heart attacks, we kind of make a jump to saying LDL is dropping, and that's an issue. So the other thing is, there's a kind of a culture where, we're the doctors, medical doctors are the guys with the prescription pads. We have license to prescribe drugs, and so that's kind of our main focus. That's kind of what differentiates doctors, people with prescribing power, from other people. That we're the guys with drugs, and we seem to think that that's really that's our tool, that's our hammer, and everything is a nail. So we're going to be hitting that. So and then you have drug reps, people who kind of wander around our offices in the hospital, and they're basically telling people to, they will quickly dispense with any talk of diet and exercise because they want to talk about their drugs and their sales and that sort of thing. So so typically you'll see like this if you ever saw a drug ad. When diet and exercise fails, when diet and exercise fails, try whatever X drug that they're selling on that TV ad. I'm sure everybody's seen that, right? Anyway, drugs, medications, pharmaceuticals have been very, very successful in certain areas of medicine. So things, and that's what's given them a miracle status. Like antibiotics can be very effective, especially when you have a person with a bacterial infection. Very effective, life-saving, extends people's life. Vaccines and vaccination has really made lots of vaccine-preventable diseases just almost disappear to the point they're unheard of anymore. The other thing is HIV medicines. I remember when I was in medical school, we were dealing with throngs of people with advanced HIV. And then right about the time I graduated into residency, these new drugs called protease inhibitors came out. Miracle drugs. Basically, all those people that were in the hospital sick with end-stage HIV went away. Truly kind of a miracle. It didn't cure HIV, but it really treated it. But there's a problem. When we get to our drugs for chronic diseases, for chronic metabolic diseases, they just don't seem to work. It seems kind of crazy, but they're just not that very much effective. You think about the drugs for cholesterol. You have to treat maybe 100 people, high-risk people, before you see even one less heart attack from the cholesterol medications. Not super effective. Medicines that we use to treat type 2 diabetes, like insulin. Now, insulin is a very important drug and necessary and life-saving if you're a type 1 diabetic. However, if you are not a type 1 diabetic, if you're a type 2 diabetic, it's not actually really life-saving. In fact, it hasn't really shown to prolong everyone's life. In fact, what it does, it just makes people who are already suffering with weight problems even worse off. So that is kind of a big problem. Again, there's a thing called the NNT, the need to treat. For these drugs, you have to treat tons of people before you see maybe any benefit, and maybe no benefit at all. With the insulin, maybe it's in the negative direction. You're lowering people's blood sugar, and that gives you a false sense that maybe you're actually helping. And by the time we're done with treating all these things, and they tend to all come in groups. So if you have type 2 diabetes, you also have lipid problems, you also have hypertension, and that is and so you end up being on a kind of a cocktail. One or two medicines for diabetes, 1 or 2 medicines for high blood pressure, a statin medication or something else, and by the time you're done, you've got a list of meds 5, 6, 7 pills long. But when you look at the problem in a different perspective, not that cholesterol is the problem, but maybe insulin resistance is the problem. All that shift of focus, that shift of perspective, really makes you think, and it puts everything as from one problem, from a bunch of different problems which are not related to each other, to one problem which all have a single cause and maybe one single solution. I was watching a TV commercial the other day where they showed a bunch of random light bulbs on the screen, making no sense. And you see these random light bulbs, and the camera shifts perspective. And eventually, you get to the right spot on the floor, and all those random light bulbs actually are arranged to form a picture of one giant light bulb. And that's kind of what I think. Where things which looked like random and in no pattern, once you switch to insulin resistance as your primary model, a lot of these problems fit together like the puzzle pieces just all seem to fit together. So anyway, the big medicines that we're using for the metabolic problems: statin medications, insulin, medicines which make your pancreas work harder, that sort of thing, aspirin. These are all things that you'll find people on. This morning in the hospital, I had people on these cocktails. It's every single day. So why did I get into this? So we got more than 40%, the most recent statistics, more than 40% of Americans are obese. rises every year. And that's just a subset of people who are overweight. 50% of people, at least, have metabolic syndrome. And so this is just a huge population. When I say the word metabolic syndrome to to my patients, they don't know what I'm talking about. They've never heard of it. It's just a big problem. And it's like the elephant in the room. Nobody wants to talk about all this stuff. I'm usually the only person in the chart that mentions metabolic syndrome, but it just puts everything together. I probably should tell you what metabolic syndrome is. Metabolic syndrome is a kind of a collection of physical findings that when you put them all together, it means that you have an increased risk for heart disease. But the thing which puts all these things together is basically it's a syndrome of insulin resistance. So if you have a big waistline, that's one. If you have high blood pressure, that's another. If your blood sugars are beginning to get out of control, that's another. Your triglycerides are up and your HDL is down. Those are the rest of them. There are 5 components of the. There's a couple different definitions, but the ones that I use the CDC definition. 5 components, and basically when I see a patient in the room, I sit there and I look and I'm counting up those risk factors. And the more risk factors you have, the more, the worse problems you're going to have. Anyway, so I started talking about getting back to how I got started in all this. I had this cognitive dissonance. I started reading. I was asking other doctors, how do you tackle this? How do you tackle obesity? What do you take when you have an obese person in the room? How do you have that conversation, or what do you say? It's like, well, they say just push away from the table a little bit early. That didn't quite make sense, so I started reading a bunch of books, and I started coming across a bunch of people. Like I started with Michael Pollan. I learned a lot from Michael Pollan, enjoyed his books immensely, period. Still had some questions after moving from Michael Pollan. Then I ran into Dr. Robert Lustig, where, he's very passionate about sugar, and a lot of the stuff he makes a lot of sense. And then eventually I started reading, one of the biggest influences that finally made me switch over to eating low carb myself was actually reading Gary Taubes' book, Why We Get Fat and What to Do About It. I mean, he just makes so much logic. It's incredible. The logic that he applies is incredible. So if you haven't read that book, I really would recommend that book to pretty much everybody, period. All right. So in medicine, it's possible to really ignore issues of fat when you focus very narrowly on the subject. So somebody comes in, and they've got atrial fibrillation, which is a problem with the heart. They've got high blood pressure, diabetes. You can just go through and you can itemize all those different issues and never really get to the unifying theory behind them, and not even mention weight problems. So that's exactly what I see a lot going on in medicine. In fact, this is kind of baked right into the traditional medical system. We've got a code. It's called E66.3. So what is E66.3? Well, that's what we call an ICD-10 code. It's a billing code, and it's obesity due to excess calories. There is no such thing in our medical billing world as obesity due to excess carbohydrates. It's just, or any other reason, but that's the paradigm that the traditional medical world works with. So how did I used to practice? Well, I used to see people come in with small elevations in glucose. I didn't really think too much of it. Very common. That's maybe your glucose is 105, 110, 116. Yeah, no big deal. Very common. Yeah, don't worry about it. It's very common. Now I look at it as, oh my God, well, this is pre-diabetes here, and this is something we need to look at. We get scans all the time, scans of people's abdomens, either a CAT scan or an ultrasound. You would find fatty liver on almost, ubiquitous. Every scan has a little bit of fatty liver. The radiologist always will comment about it. And he was like, don't worry about it, that's in everybody, not a big deal. Now I'm like, oh my God, canary in the coal mine. This is insulin resistance. This is the seed of insulin resistance right there. High uric acid levels. Well, that's only important if you have gout. But now I look at it as kind of a sign that the person's consuming too much sugar. The other thing is, lipids. I read a lipid panel completely different than I used to. Before, I would really primarily look at that LDL number and then treat that. Now, I'm not a big fan of LDL at all, and now I'm looking more at triglycerides. I'm looking for high triglycerides, I'm looking for low HDL, and that's what I'm figuring out, and I'm applying lifestyle management to that. So the other thing is, and if we did see a very high triglyceride, we would say, well, maybe you should go on a fibrate or something like that. I remember back with my animals in the lab in college, we used to see these lipemic specimens where literally a third to a half of that blood volume was actually made up of triglyceride. Now these were animals which were getting ready to hibernate, so that was probably normal for them. But unless you're a hibernating groundhog, I don't think you want triglycerides that high in a human. So what do? Now I love to talk about weight. Before, it was really, I was kind of ashamed of it, didn't really want to bring it up. Got a person there, didn't know how to do it. I did get help when I started going to some obesity conferences. I learned how to broach the topic, but now I get excited about it. Why? Because I think I have a solution for people. Whereas before, if the solution that they've been applying doesn't work before, it just doesn't work, and you don't really want to talk about it because you could tell people that they should lose weight, but if you don't know if you don't know what to tell them, it's kind of not even worth bringing up in the first place. So I talk a lot more about it than that. During my office visits with people, what am I doing? I'm spending a lot of time looking at pictures of food, talking about food. It's not just a click box. The electronic medical records, they always want you to click off diet counseling. It's in there, but it's just a click box for most doctors that they quickly click through, and I spend a lot of time actually doing dietary counseling myself. I don't have really a dietitian who I rely on to help me with my with the diet. So how did I learn about this? Well, I started listening to a lot of audiobooks. Again, Michael Pollan, Gary Taubes, Lustig, Nina Teicholz. These were very, very important people. And basically, once I saw that, giant light bulb went on over my head. Eventually, as I was reading Gary Taubes, I found myself switching over to a low-carb diet. And so when I started doing this, I was getting to be a little bit overweight myself. I always thought of myself as a thin person, but it was beginning to be less and less true. My pant sizes were expanding over the years. I developed a snoring problem. I had reflux almost every day for about 10 years. And I would be taking a proton pump inhibitor. That's a medicine like Prilosec, which suppresses acid production. And we know now that being on those for a long period of time, not a good thing. You have long-term complications from that. Increases your risk of pneumonia, which I see all the time in the hospital. Very rare that I ever admitted a patient to the hospital for pneumonia who is not on a proton pump inhibitor. So I did this and started doing this myself. And my wife took notice because I was kind of skipping over all the starch dishes that we would make in the house. Eventually, within 2 or 3 months, it all went away. It just vanished. The heartburn. And to be honest with you, I didn't even know that it was going to happen because that time I didn't really have all that information. And I just noticed that all of a sudden I'm not using proton pump inhibitors anymore. I'm not reaching for that bottle of Tums anymore. Completely gone. And eventually 6 months or a year down the road, I realized, hey, when was the last time I had a headache? Headaches vanished. Really strange stuff. I used to snore, used to have a double chin, all that stuff kind of went away. And it really, for me, I lost about 20-25 pounds within about 2 months, and I pretty much stayed that way then. And the funny thing was, when I first started low carb myself, my hip was hurting me. I had tried to run a 5K race, or I did run a 5K race, kind of in the period of keto adaptation or fat adaptation, and after I did that, my hip was really bothering me, and so for a bunch of months while I was starting low carb, I wasn't really exercising much at all. So, you know, in order to lose weight, you do not really have to exercise. Obviously, exercise is good for you for fitness and health, mitochondrial activity, but really, it's not the way to lose weight. You do that all by making the proper food choices. So those are all the things. Also, one more thing that improved, gassiness. So if you're always farting, holding in a lot of stuff, then that's uncomfortable. And that, barely all that gassiness just basically went away. I had some mild allergy symptoms. I would mow my lawn. I would sneeze a couple of times mowing my lawn. That doesn't really even occur anymore, and I'm going to attribute that to the diet as well. So anyway, once I started reading these books, I ran into a cardiologist who was kind of had a preventative mindset. He was actually a former cath doctor, and he told me that, hey, listen, why don't you sound like you like this diet stuff? Why don't you go to this conference? And he went to what's called the ASBP, the American Society of Bariatric Physicians, and he said, why don't you sign up? Why don't you think about going to this conference? Now they've since changed their name to the Obesity Medical Association, and he gave me the syllabus where it had all the people who were speaking there, and they were like people who I just read, like Dr. Lustig was there, and Eric Westman was there. He was actually the president of the society, and Sarah Hallberg was there. And all these people were at these conferences. Like, I need to start going to these conferences and learn from these people. And so, and I also learned, hey, you can go there, go to these conferences, do some studying, and you actually can get certified in obesity. And I said, wow, that seems like something important to do, because once I have like a little certification, I can actually, like, instead of just being kind of a routine run-of-the-mill family doctor, I can actually, maybe make some changes in my medical community, and with a little bit of extra certification under my belt, maybe that would hold a little bit more credibility. Because basically, we're going off script when you go low carb, you're going off script. So anyway, so the ABO, so the courses for that, all different types of people. They teach you how to use low-calorie meal replacements. Wasn't really interested in that. I really just went there to talk to people who I began to idolize, which were people like Westman, Hallberg, and Dr. David Ludwig, who were speaking at these conferences. Eventually, I went online. I discovered all these other people, DietDoctor.com, Andreas Einfeld. Ran into people, just very, very educated, smart people like Ivor Cummins. Ran into Jeff Gerber, who's a fellow graduate of Temple University. So I was looking around online to find out that there was reputable people out there doing this. Eventually, I found that there was a guy who was from my residency program. He was our chief medical resident, and he went into, and he did a study in 2004 where he took veterans, put them on the Atkins diet, and he was able to get them off medicines. This was very important. This is one of the things where I found out, aha, not only is this diet good for losing weight, but it's also good for making people healthier, and that's my main goal. The other person was very influential on me, Ben Goldacre. There's a book called Bad Pharma, where he kind of says, many of the drug studies that we depend on to know that drugs are working basically have a lot of flaws. maybe some of them even purposeful flaws, and that's a problem. And so maybe we shouldn't be relying on drugs so much because we just don't know as much as we think we should know about these drugs. So low carb diets, what do they fix? In primary care, they fix an awful lot. I kind of get embarrassed because it's embarrassing because when I start listing all the things which might get better when you try a diet, it just kind of sounds silly because it sounds like a panacea that you're going to fix everything at once. And it's almost too good to be true. So just quickly, I mean, weight obviously, diabetes, lipids, triglycerides, fatty liver, gout, gallbladder disease, hypertension, ADD, depression, anxiety, allergies, eczema, I'm sure you guys can tell me what your personal problems were, and there's more and more and more. And the more you look at it, the more things get better. So for me, it's a no-brainer. All without any side effects, all with less meds. What a win. Of course, so me as a doctor, I do a lot of my dietary counseling myself. I set up a website because I simply do not have time during an office visit to get into all the nitty-gritty details, even though I still spend a lot of time doing it. But the big thing we got to know is if you're on medications, we need to watch them like a hawk, especially diabetes medicines. If you're coming off diabetes medicines, usually what I do is I say day one, we're cutting things in half. If you're on insulin, we're going to cut that in half day one. I do not want your blood sugar to crash. I do not want you to become hypoglycemic. That could be life-threatening, could land you in the hospital, life-threatening. So we want that. And so we want to be measuring your blood sugars very, very carefully several times a day while we're doing this. Blood pressure medicines, those will need to be reduced. I don't want you to be passing out, falling out, syncopizing, crashing your car. And that's not a good idea. So those things, get a blood pressure cuff. We need you to keep watching it. And if you're feeling woozy, pay attention to that. That's a very important thing. Other medicines which can eventually we could just stop because maybe you don't need them anymore. Proton pump inhibitors, allergy medicines, asthma medicines, medicines for eczema, those things can all get better. So the other thing, so before I usually launch in and start telling people to you change your diet, usually I want to get people motivated. I use a checklist. Basically all those things which I list there, I have a piece of paper and I check them off. Oh, you're overweight, that might get better. Your diabetes, that will get better. Oh, your blood pressure, that might get better. Your allergy. So I have a list, and then I total them up. Oh, we've got 5 things which would get better if we just simply change your diet. And usually that would say, that's usually enough to get somebody to say, aha, maybe this is something we should do. It's more than just a weight problem. This is not just an aesthetic issue, but but all these health issues get better at the same time. So my response from my patients, a lot of them are very appreciative. They really do not have a doctor who's ever really talked to them about diet before, at least other than eat less, exercise more, and there you go. And here's your prescription. A lot of people are very appreciative of this. Not everybody, though. Some people are very skeptical. They wonder why they're hearing a different perspective. They're wondering why, if everyone else says eating this stuff might kill me, why does this doctor say something else? And I simply just have to make some explanations and then refer them to some excellent books, like if you're worried about fat, read Nina Teichel's books. If you just need to get the perspective together, you want to read Gary Taubes, that sort of thing. And there's the other thing is, people really kind of get sad when you tell them you're going to be taking away their cookies. In Philadelphia, where I am, tasty cakes are the big thing. That was a hard thing for me to give up, tasty cakes. And some people are pleased, some people are confused. It's just the way it is. All right, so yeah, some people, even when you mention cancer, they can't believe that you can affect cancer rates by switching your diet around, which I kind of intimate. I don't know if I've convinced very many cancer patients to change their diet. The last conference I went to in Tampa, I was sitting next to Dr. Seafried, who's the big cancer researcher for using metabolics as that approach. And I just look at it as quite a shame when I see cancer patients gorging on candy and lots of starches and carbs, and I wonder if they would do a whole lot better if they had made some dietary changes. Of course, in addition to their standard, conventional chemotherapy, radiation therapy, and surgical interventions. So when you come into the office here, what do we do with you? How do we assess you? We get your height, your weight, your blood pressure, obviously, just like any other regular doctor. We calculate body mass index. That's pretty much standard. The computer automatically puts that in. When you put in height and weight, body mass index automatically gets calculated. Body mass index, obviously, not a perfect measure of weight, but if most of that's around your waist, then it's a bit more effective. But I'm also measuring waist circumference, getting a waist to height ratio. So waist to height ratio is probably the most important thing that in the world. If it's close to 0.5, your waist circumference to your height, that's ideal, and that is associated with all sorts of good things. And the higher that number goes, the more problems you have. If you go to a 0.59, then you're really in trouble, or you're going to have high risk for metabolic disease. Let's see. So things I don't really measure: fat impedance. That's where you hold onto the little metal probes, and it gives an estimate of your fat percentage. Not very effective, and I don't measure that. DEXA scans. That is an accurate way. In general, I don't think it gives me a whole lot extra information, even though that would probably be the gold standard of measuring fat percentage. I'm not using that too much. Fat calipers also rather inaccurate. Really, the most bang for my buck is waist circumference. Screening tests. What do I do in the office? I'm pretty basic. I don't do a whole lot of stuff, but I do things which a lot of people don't do these days. The biggest change that I've done recently was move into using HOMA IR. Using HOMA IR, that's something that I didn't use in my previous life. I use lipid NMRs a lot. So NMRs, that's basically the advanced lipid panels, where you're looking at LDL size, particle number, that sort of thing. It gives you a much more detail. If somebody's really freaking out about a high LDL, I can use that and say, listen, you've got a healthy pattern, you've got large, fluffy LDL particles, which are not associated with heart disease, and you don't have to relax. Of course, if you've got all the other parameters of that go along with insulin resistance, it's going to be, you can probably pretty much guess that they're going to have small, dense particles, because most people with a lot of metabolic syndrome will be pumping out the small, dense particles. Other things which I sometimes occasionally will write, HSCRP, that's C-reactive protein. Inflammation gives you an idea whether or not you're producing a lot of inflammation throughout your body, and increase your risk of everything else going, having heart attacks and strokes and that sort of thing. SED rate, uric acid again, too much sugar in the system. Your body is making lots of uric acid as a waste product from turning carbs to fat. Coronary arteries, CAC scores, coronary calcium scores, those are useful to actually show proof positive if you already have heart disease there waiting to go, which could eventually lead to a heart attack or cause angina down the road if you didn't know about it already. That's the other thing. So what are the big things which improve on your labs? Diabetes. So A1C usually collapses. If somebody really does it hard, I've seen people's numbers, your A1C will drop from 11% to 5.9, just collapse in a couple of months, really go down. It's not that unusual. Triglycerides, very, very sensitive to low-carb diets. Usually that falls. HDLs usually will go up. So you see people with very low HDLs, 35, 30 numbers, and then they go up into the 40s. And so that's really good to see. Insulin levels fall, fasting insulin levels fall. So just quickly moving into the hospital realm, I see it, every morning I go to the hospital, I see lots of people. They've got lots of medical problems this long. It's a little bit of a challenge to practice low carb in the hospital. Most hospitals are not set up with low carb. It's not even in their, low carb diets are not really on the menu there. So you kind of have to jury rig it, you have to demand it. You have to just refuse to eat some stuff. I would just refuse to eat altogether. And that would be, and that's kind of how you have to handle it here. Hopefully, in the future, we can set up protocols, get everybody on board, the nurses, the dietitians, the doctors. But those are things that we're going to have to work on doing. So it can be, the hospital could be great because it's a teachable moment. Somebody came in with an acute event, their diabetes out of control, they've even had a heart attack, they had a stroke. You discover all these, and a lot of times it's news to them. They didn't even know they're diabetic. They didn't even know that they had heart disease. And this could be a teachable moment. There are some barriers there because if the person is really sick, they could be out of it. If they're in pain, they could be on pain-controlling drugs. They might not be able to comprehend. The other thing is, from my standpoint, we're very busy in the hospital. We've got a brief period of time to see a lot of people, and it takes a lot of time to do proper dietary counseling. But when it works, it's wonderful. People are very appreciative of it. Let's just see. So in the hospital, I've gotten some of my colleagues on board. I've talked to some dietitians. They're very interested in it. Dietitians can be kind of, restrained by their protocols, the corporations they work for, the food service companies they work for, the food that they have available in the hospital. They can be kind of limited. So that's a problem. The other thing is, nurses and doctors, well, a lot of us, we don't have the best eating patterns. And I've had a couple people come up to me and start using what they call my diet, which is not really my diet. Most of my diet is actually I stole from Dr. David Unwin, but it's not my diet at all. But when they start doing low carb, then all of a sudden their weight starts to fall off. And the other nurses on the floor take notice. When one of them loses weight, the other ones take notice. And they change different. I've had some of my colleagues, doctors, people who have had heart conditions start on the diet, lose a lot of weight. One of my most effective is as a doctor whose A1C improved, by leaps and bounds by doing this, and very appreciative of this. It's very gratifying to see, especially your friends and colleagues get better with this. So the biggest things in the hospital, the reasons why I see people in the hospital with weight problems and insulin resistance problems, cellulitis of the legs. If your legs are big and swollen all the time, you end up getting infections there. We see overweight people get blood clots in their legs and then into their lungs. We see people in kidney failure from diabetes, uncontrolled diabetes, hypertension. These are things, headaches, gout, gallbladder, acute gallbladder attacks. These are all diet-related issues, which brings people into the hospital, and lots of issues. And a lot of people have no clue that this was actually all brought on by diet. Let's just see. Also in the hospital, we see lots of problems with our hospital patients. If you're a big person in the hospital, it's harder to get imaging studies on you. We used to have problems with people just, the machine was not even equipped to handle super heavyweight people. Now I think most of our equipment has been upgraded to handle heavier people, and so that's less of a problem than it used to be, except for in the most extreme cases. Also, the quality of the imaging studies is worse. We try to do an ultrasound. It's really hard to get good ultrasound pictures through a big layer of subcutaneous body fat or a lot of intra-abdominal body fat, a big problem. Let's just see here. So, so severe people can be more expensive to treat in general. They need bigger beds, which cost more money to rent. When it comes time to discharge, big people, especially nursing homes and rehab facilities, they're not very well equipped to do it. It takes more staff to take care of them, to move them, to transfer them. It takes a lot. Staff injuries increase with heavy people, so it's a big issue. And sometimes I've had people actually have to stay in the hospital because really we have no place to put them. It's kind of sad and disgusting because we cannot really discharge them from the hospital to a safe setting. In general, these people are staying in the hospital longer, so it's a big issue. So in wrapping up here, final comments, I think low-carb approaches have really enhanced my practice, shift my perspective, puts all these separate issues, which I thought were unrelated, into one framework. Makes all the puzzle fit together. And I allow people to be more empowered. You're not just taking pills that I'm giving you, you're actually every day with every meal, you're helping yourself. And that's really super gratifying. People really feel that they're in control, and it's not me just dispensing statin medications to people, and people are really super impressed with that. And that's basically it here, folks. I don't know, I think I went a little bit longer than I intended to, but hopefully I didn't ramble too much. If you want to find me online, I'm on Twitter. Very active on Twitter, and Twitter's a great place to kind of interact with people. It's like an online journal club, and there's lots of information there. If you start to follow the right people, you can really learn a lot from very smart people there. I also have a website. It's called the Phoenixville Nutrition Guide, which is my website, which I kind of hand out to all my people, where I send them to go and to start to get some learning. DietDoctor.com is also a great place to get started. So you can also see, if you're interested, you can see me in the office if you live reasonably close. I have office hours. You can look me up, and you could schedule an office visit. Anyway, well, thanks for watching me, listening to me, and have a great day.